Good morning, ladies and gentlemen. Welcome to another monthly meeting. We have been holding this monthly meeting since July 2020, and then we had several experts on our screen. Most of the experts, they unfolded about COVID pandemic, its epidemiology, pathology, evolving treatment, and the discovery of vaccine. Well, thanks to vaccine, now the UK has been very successful, and the second wave COVID pandemic is gradually settling here. So now we thought time to switch over to other common problems. One of the common problems is the complications of hypertension. I think most of the members in this audience have hypertension, long-standing, and the long-term complications can hit the brain and bite the heart. So how do we save our hearts from the complication of hypertension? To tell this, we have an expert from Cambridge, Dr. Jayan Parameshwar, consultant cardiologist at Papworth Hospital. He is going to talk about cardiac failure, which is a common complication of hypertension, and so what is new and how to treat it. To introduce Jayan, we have his longtime friend Rangarajan. I believe they both met first time in the Lovedale School in Kunnur, and they're still connecting each other. Rangarajan, please introduce Jayan to us.
Thank you, Dr. Raju, and thank you, Jayan, for accepting our invite. I welcome you all to our Zoom CME. This is the MSMA CME, as our President, Dr. Shanmuraj, has said. We hold monthly CMEs. This time of COVID, it's all virtual and Zoom. It gives me great pleasure to introduce today's speaker, Dr. Jayan Parameshwar. He is the consultant cardiologist at the Royal Papworth Hospital NHS Foundation Trust in Cambridge. That's his full designation. But he is a close friend of mine, and as Raju said, I know him from my school days, which goes back to 60s and 70s of the last millennium, right? So now Jayan has an excellent clinical and academic track record. He he did his undergraduation in Jipmer, Pondicherry, and then went on to AIMS in New Delhi for his MD medicine. After that, he came to UK and did further studies in cardiology in Hillingdon and the National Royal Brompton and Heart and Chest Hospital in Brompton National Hospital. He also learned further, did further work in the Royal Papworth as a trainee and now as a consultant, and his achievements are in the advanced heart failure management and heart transplant field. So he is an expert in managing advanced heart failure, both preoperative selection of patients for transplant and postoperative care, and also in mechanical circulatory support. We know, most of us know about mechanical ventilatory support, but mechanical respiratory support we know, but mechanical circulatory support is equally crucial for a lot of us, as there is hypertension leading to heart failure and other things. But if we remember what we learned in pharmacology and medicine in those days, all we knew was digoxin and the loop diuretic Lasix, right? That's all, those two drugs we managed for quite a while. But now there's a big armamentarium of drugs and other devices, mechanical assist devices. And I don't want to get into the talk or the slides, but to tell more about Jayan, I mean, he, as I said, he's got a vast clinical and academic experience. He has been involved in transplantation and management with the mechanical circulatory support for over 30 years.
Okay, can you all see that?
Yeah.
Great, thank you. First of all, I'd like to thank Ranga and Dr. Raju for calling me here. I'm really honored to talk to all of you. Strictly speaking, Pondicherry is not part of Madras State, so MSMA. But at least in our time, JIPMA was part of Madras University. So we at least have that much of a link. Now I know there are separate universities in Pondicherry and so on. So anyway, it gives me a great deal of pleasure to join you. And I'm not going to talk much about, I'm not going to mention heart transplantation or talk much about mechanical support. I'll try and confine myself to the pharmacology. But if you want to talk about the other things when we're talking to each other at the end of the talk, I'm more than happy to go into that. Okay?
Yeah.
So back in the 18th century, this is what Voltaire said about us. Doctors are men, because then they were all men, not like now, who prescribe medicines of which they know little to cure diseases of which they know less. In human beings of whom they know nothing at all. So things have changed a little bit since then, I think. But the field of heart failure, although it's you might think it's an old field, most of the therapy we now use is actually relatively new. So back in 1980, when I was doing my MD in Delhi, there was a new textbook of cardiology that came out in 1980 by a famous cardiologist called Eugene Braunwald. So if you look at that first edition of the book, and what they spoke about treatment of heart failure, 80% of it was, as Ranga was saying earlier, digitalis, diuretics, and bed rest. That's it. But of course, over the last 40 years, which is most of our sort of treatment lives, if you like, the time we've been active in the field, things have evolved a bit. So digitalis, of course, was first used in the 18th century here in the UK, as you know. And after that, for about 150 years, there was no real advance in the treatment of heart failure. And DIG itself now has a very small role in the actual management of heart failure. It has gone down in the amount of use. The next real development is when mercurial diuretics were introduced in the 1930s. And mercurials did work, but they had a lot of side effects. They were very toxic, so they stopped being used. Next came the thiazides, like benroflumethiazide and so on in the 1950s. And they are still used, of course. And the first loop diuretic, Lasix of furosemide, was only introduced in 1964. And it's interesting to think that the first human heart transplant came in 1967. So at the time when the first heart transplant was done, the only medical therapy was digoxin and diuretics. So actually, most of the people who required transplantation in the 70s and 80s would not need transplantation now because of the more effective therapy. 1970s, people started using vasodilators in heart failure. But in fact, the first randomized controlled trial of any drug showing a mortality benefit in heart failure was in 1987, which is when ACE inhibitors were tried and shown to decrease death rates in heart failure. And following the introduction of ACE inhibitors in the 80s, you then had the angiotensin II antagonists, which are similar. And then in the 1990s, there was again a real shift. Now, most of us, when we were in medical school, we were told that beta blockers are contraindicated in heart failure. Asthma and heart failure were the absolute contraindications. If we had said use beta blockers in heart failure, we'd have failed our MBBS exam, I think. But of course, things changed in the 1990s when it was shown that at least in chronic heart failure, beta blockers could have a beneficial effect. And they entered the therapeutic armamentarium. If you ask a medical student today, what drugs do you use for heart failure? First thing they'll say is beta blockers, which is the opposite of what we would have said. Also in the 1990s, the aldosterone antagonists or mineralocorticoid receptor antagonists, spironolactone, old drug, but came back into the use of heart failure. So this was the establishment of drugs in between the 1980s and 1990s, and that was the standard therapy then for a long time. I'll just briefly go over the evidence for these, but very, very briefly before I go to what is new. So this was the ACE inhibitor trial in heart failure. This is enalapril, 10 milligrams twice a day versus patients on on diuretics and DIG. And this is only a 12-month trial. You can see, if you look at the placebo arm, more than 60% of patients had died. In the enalapril arm, about 45%. So it was about a 1/3 decrease in the death rate. But the important thing is that the absolute death rates you can see were really high. In the 1990s, as I said, spironolactone, which is a very old drug, was reintroduced because of its mineralocorticoid blocking effects. And as you can see here, in patients on DIG plus diuretics without ACE inhibitors, DIG, ACE inhibitors, and the diuretics, spironolactone again had about a 1/3 decrease in the heart failure rate. And soon after that, there was a trial with the next generation, if you like, of mineralocorticoid receptor antagonists with the drug eplerenone, which is not more effective than spironolactone, but has fewer side effects. And this trial is actually a post-MI trial, but it's now used in heart failure as well. Several beta blocker trials were also came out in the 1990s and showed the role of beta blockers. This is one of them. And you can see the cumulative mortality in the beta blocker arm is about, again, 1/3 below that what it was in the placebo arm. So all these drugs had about 1/3 effect, if you like. So by the year 2000, the established therapy for heart failure was diuretics, ACE inhibitors, beta blockers, and spironolactone. And that remained the established therapy for a while, at least as far as drug therapy was concerned. If you fast forward to 2021, this is what heart failure therapy looks like. You've got all sorts of arms running everywhere. So you can think of hundreds of things to do. And the important thing is to choose the sensible intervention for each patient. If anyone wants any of my slides, I'm happy to share, so don't worry. So a few brief words about the established therapy before we go to anything new. It's interesting that in spite of all these therapies that we have, the single commonest mistake that I see when patients, so we often transfer patients from other hospitals, including other intensive care units. That's our main role. Patients who have been managed with heart failure. And even when they come from established cardiology units, the commonest problem we find that underuse of diuretics is still the biggest problem. So most patients need more than they get. When patients get worse and renal function gets worse, actually they need higher doses of diuretics to work, not lower doses. Bumetanide and furosemide are the commonest ones used. When patients are volume overloaded, they've got a lot of edema, their gut also has edema. Bumetanide might be better used when you give it orally. It might be absorbed better. For intravenous use, it doesn't matter. In decompensated heart failure, most patients will require intravenous the diuretic. And of course, hypokalemia is a common problem that we got to watch for. Few words about troubleshooting for ACE inhibitors. And this is something which anyone uses these drugs will find. The commonest problem is renal problems. What do you do when renal function gets worse? So these are guidelines which is jointly produced by the British Society of Heart Failure and the Renal Association. So if the rise in serum creatinine is less than 30% and the estimated GFR is more than 30 and potassium is less than 5.5, you don't have to adjust the dose, but check the creatinine electrolytes again in about a week. If the creatinine rises more than 100% and or the eGFR is less than 25 or potassium is more than 6, stop the ACE inhibitor or the A2 antagonist or the MRA and ask for help. Anything in between, cut the dose. I would halve the dose normally and check again in a week. So it's important to remember that even with worsening renal function, ACE inhibitors have a prognostic benefit in heart failure. So it's a question of how bad it is. So if it goes up a little bit and plateaus there, it's perfectly reasonable to continue with the drug. And a few words about beta blockers. I think in new onset heart failure or acute decompensation, I would caution against starting a beta blocker too early. There is a reason why we were taught that it was contraindicated, because in the short term, it can make you worse. So if you introduce it too early, patients might deteriorate. So the best advice is wait till the volume status is normal. Wait till you got rid of all the excess fluid, then start the beta blocker. Start with a very low dose, gradually increase, aim for a heart rate at rest of 60-ish. 50 to 60 at rest is also okay. If systolic blood pressure is below 90, don't increase the dose. And of course, in those patients who have increasing AV block, we can't afford to increase the dose. In some patients, they will need an increase in diuretics when you first introduce beta blockers, and both the patients and us, we need to be warned about that. So that's the basic of these drugs. Okay, 2014, there was after 15 years, there was a new drug, if you like, in heart failure. This was called the Paradigm study, and therefore it was a paradigm shift. So the new drug is what's called an ARNI, and ARNI stands for AR is angiotensin receptor antagonist, and the NI is a neprilysin inhibitor. The angiotensin receptor antagonist used in this trial was valsartan. The neprilysin inhibitor is a drug called sacubitril, and these are now, it's sold as a sacubitril valsartan combination drug, which is marketed as an Entresto. So Entresto consists of these two drugs. On the right, you can see the renin-angiotensin system, and if you remember your physiology from second year and so on, the effects of the renin-angiotensin system are to increase blood pressure, increase sympathetic tone, increase the secretion of aldosterone, increase fibrosis in the heart. And that is blocked by the valsartan. And that, of course, we all know about because we've been using that effect for a while. The second half of the drug, the sacubitril, blocks an enzyme called neprilysin. What neprilysin normally does in the body is to break down certain vasoactive peptides. And the common ones are up there, which is PNP, which is actually stands for brain natriuretic peptide, which is actually released from the heart. Yeah? These peptides have beneficial effects in patients with heart failure. So they actually lower the blood pressure, they vasodilate, they decrease aldosterone levels, they decrease hypertrophy, and they increase the amount of sodium excretion. So we want these drugs to be there in heart failure. So using an neprilysin inhibitor means these drugs will persist for these peptides will persist for longer, and therefore you get the beneficial effects. So the combination of the two give you all these properties which we want in the heart failure patient. So Entresto was used in a trial, as I said, called Paradigm. This was moderate to severe heart failure, 8,000 patients roughly, randomized to enalapril or this combination of sacubitril valsartan, and death or first heart failure hospitalization was the endpoint. And what it showed was effectively you got about a 1/5 decrease in the rate of the primary endpoint, death and heart failure hospitalization. So Entresto, this is what you will get. You'll get about a 1/5 decrease in the sort of combined endpoint of death or first heart failure hospitalization, and a similar 1/5 decrease in the absolute cardiovascular mortality and of first heart failure hospitalization. Also, there's a decrease in heart failure symptoms and a better quality of life. But in some patients, especially those with severe heart failure, we'll find that renal function can get worse, so you have to be very careful. And some patients, actually, you'll drop the blood pressure even more than we want to, because both the drugs have an effect that increases the amount of vasodilatation. And NICE has brought out these guidelines as to who should get the drug. Essentially, what they say is moderate to severe heart failure, stable on a dose of ACE inhibitor or an A2 antagonist, you can switch to this new drug. And at the moment, they say it should be started by a heart failure team. Dose titration should be done for a period of about 6 weeks, and then primary care can take over the prescription of the drug. The next change occurred in 2018-19. So the sodium glucose co-transporters are proteins in the proximal convoluted tubule of the kidney. And what these proteins do is they lead to reabsorption of the filtered glucose. That's their primary role. So the drugs that block this, sometimes called the gliflozins, because that's what the name of the drugs are, they block this, and the effect of that is you increase the amount of glucose secreted within the urine. So not surprisingly, these are drugs which were introduced for the treatment of diabetes. But as the trials in diabetes were done, it was found that actually diabetics with heart failure had a beneficial effect with these drugs. And then in 2018-19, we had, for the first time, we had the evidence that these drugs have a beneficial effect in heart failure, whether the patient has diabetes or not. So now they have been approved for the treatment of heart failure per se. They don't have to be in diabetic patients. There are actually many non-renal effects of these drugs, and we don't fully understand all these effects yet. But the metabolic effects in the mitochondria, in the liver, and various other parts of the body may be as important as the renal effects. So although we know they're beneficial in heart failure, we don't know all the beneficial effects in heart failure. We can't explain all the benefit purely by the renal effect. And there were two trials, one called DAPA-HF, which used a drug called dapagliflozin, and one called Emperor, which used empagliflozin. And they both had very similar effect, about a 1/4 decrease in heart failure, hospitalization, and death with these drugs. So both have now been approved, and NICE has approved them for the treatment of heart failure. Both trials were similar, but the DAPA-HF excluded people with type 1 diabetes and those with an eGFR below 30. The one with empagliflozin excluded patients with ketoacidosis and with an eGFR less than 20. So even patients with quite severe renal dysfunction seem to, you can use these drugs. And the third drug of this class called sotagliflozin, this data came out only 2 months ago, so it's still early and we'll get more data. There's another trial in heart failure, but this included two special extra points. They included people with acute heart failure, not just chronic heart failure. And no other drug has been shown to benefit people with acute heart failure yet in a randomized controlled trial. And secondly, they also included people with ejection fractions that are normal. So this is so-called diastolic heart failure, or heart failure with a preserved ejection fraction. And again, almost no drug has been shown to have an effect in this class of patients with heart failure. This is the first one. It's still early data. As I said, this trial was only came out in New England Journal in 2 months ago. So I'm sure more data will be available. This is not a NICE approved indication yet, but I think it is likely to come within the next year or two, we hope. So the take-home messages from these drugs are, they cause a loss of glucose in the urine. Associated with that, there is free water, which is also excreted, and a lot of non-renal metabolic effects. There also seems to be some increase in sodium excretion, because after all, this protein system is called a sodium glucose co-transporter. So sodium excretions also increase, which is why it helps in heart failure. So using it, you'll get about a 1/4 benefit. This is on top of ACE inhibitors, beta blockers, spironolactone, and so on. They improve heart failure symptoms. They decrease cardiovascular death and heart failure hospitalization. And they also slow the progression in renal dysfunction seen both in diabetes and in heart failure. And we also expect that they will have beneficial effects in hospitalized patients, that is in acute heart failure, and in those with heart failure with preserved ejection fraction. And they may be particularly useful in patients who are volume overloaded in spite of loop diuretics and where the serum sodium is low. Why? Because they cause free water excretion. All us old people will know who these are. These are, of course, the Beatles, who were sometimes called the Fab Four. I don't know whether you remember, they were called the Fab Four. Well, some wise guy has called the new 4-drug treatment for heart failure the Fantastic Four, akin to the Fab Four. And the Fantastic Four are, of course, excuse me, the older drugs, beta blockers, the mineralocorticoid receptor antagonists, the ARNIs in place of just ACE inhibitors, and now the SGLT2I. So these are now the Fantastic Four for heart failure. What does this mean for our patients? Well, if you take an average, so somebody has worked out this net benefit, if you like. A 60-year-old with heart failure treated with a beta blocker and ACE inhibitor and diuretic if they need. If you add spironolactone, convert from ACE inhibitor to sacubitril valsartan, and add dapagliflozin, it is estimated that you will gain up to 5.5 years of increased life, which actually for a pharmacological therapy is extremely good. And if you take event-free survival, that is death or heart failure, hospital admission, up to 7.5 years. So actually, that's pretty good. You're getting quite a lot of benefit from these drugs. This is real. It's something you see in everyday life. It's not just something you can work out in a paper. You know, if this is you can see a big heart, someone with heart failure, after treatment for 6 months to a year, you can see the heart size shrinking, going back to near normal. And that's something we see more and more of. However, I have to say, not every patient is going to get as much benefit as that. Excuse me. Few other points. Iron deficiency has become a very important thing in heart failure. So our renal colleagues know much more about this. They've been treating iron in renal failure for a long time. But increasingly, the role of iron in heart failure has become important. And this is not iron deficiency as we normally think about it. Hemoglobin will be normal. You won't get a microcytic hyperchromic blood picture or anything like that. This is a lack of iron stores. And this is defined on the basis of a serum ferritin below 100. Now, if you look at your lab values that you get from the lab when you ask for a serum ferritin, below 100 is not marked as abnormal. I think your range is to 20 onwards. They will quote as normal. But to maximize iron stores, a ferritin we think has to be higher than what we normally think. So this was a group of patients in my hospital, actually, 700 patients with advanced heart failure. When we checked their iron, about 300 had a ferritin below 100. A further 77 have what's called functional iron lack, which is a ferritin between 100 and 300, but a transferrin saturation below to 20. So these are not patients where we would have conventionally used iron at all. But it has been worked out in randomized controlled trials that all these patients have a potential benefit with replacement of iron. Patients who have low iron in this way, when you measure their exercise capacity, have a lower, it is lower. So if you do a 6-minute walk, they walk less. If you measure their oxygen consumption with exercise, which is a more, if you like, sophisticated way of measuring the exercise tolerance, it is lower. And this is increased by giving them iron, but it has to be intravenous iron. So oral iron does not work. The intravenous iron preparations are either ferric carboxymaltose or something called iron isomaltoside. The advantage of these preparations is that they're very easy to give. It takes only about half an hour. You only need a peripheral venflon for it. And unlike the old parenteral iron preparations that we were used to 30, 40 years ago, there are no side effects. You don't get iron reactions. It's not painful or anything. So this is something we now do in everyone with heart failure. We check for iron lack, and those whose iron stores are low, we also give iron. Okay, pharmacology I've talked about. What about other things? The other aspects which have increasingly now come to the fore in the last 15 to 20 years. First was the implantable cardioverter defibrillator, or the ICD, which I'm sure all of you know about. Second thing is what is called CRT, cardiac resynchronization therapy, otherwise called biventricular pacing, and I'll show you something more about that. The third, of course, is both these joint in one device, ICD plus the CRT. And the fourth is mechanical circulatory support. This is continuous flow pumps that we use to support the heart long term. I won't talk about the LVADs now, but if you want me to say anything about it after I finish the main talk, I'm more than happy to do so. So what do ICDs do? ICDs is essentially cardiovert patients in VF, and they shock patients who are in VT. So this is an example of an ECG of someone in VF. This is sustained ventricular tachycardia. The ICD will sense this, and if it sees this VT, it will try and pace the patient out of it. If that doesn't work after a preset interval, or if the patient develops ventricular fibrillation, it will shock the patient internally. So a trial in the early 2000s compared placebo or an antiarrhythmic drug, which is amiodarone, which is thought to be the most effective drug, compared to ICD in patients with heart failure. And as you can see, after about a 5-year follow-up, the ICD arm, the rate of death is significantly lower than the other two arms. And interestingly, the antiarrhythmic drug has no effect. It's exactly the same as not giving anything. So based on this, ICDs were approved for the treatment of certain classes of people with heart failure. But ICDs, you say, okay, that good, why not put it in all patients with heart failure? Well, because the technology is not perfect. So about a third of patients will get inappropriate ICD shocks. That means the ICD will fire when it shouldn't. It's not very nice when it fires. So some patients say it's like being kicked by a horse inside you. The survival benefit that we showed in those trials may be less evident now because our pharmacological therapy has improved. And this is particularly true in patients with a dilated cardiomyopathy compared to those with coronary artery disease. With long follow-up, people have ICDs now in situ for 15, 20 years. Device-related complications like infection, also actually damage sometimes to the valve, to the tricuspid valve when you put these leads through for a long time are also possible. So they are still beneficial, not that they're not beneficial, but you don't want to put it into people who are not likely to benefit, so you need to choose your patients. And of course, no one will live forever, so ICDs prevent sudden cardiac death. They will stop you dying of arrhythmia. But what they will do is convert your mode of death. So you ultimately die of worsening heart failure. And if you have an ICD when you're dying of worsening heart failure, you'll have multiple shocks at the end, which are not going to save your life. So it's very important that the patient with an ICD, as the heart failure is getting worse with time, we have to talk to our patients about deactivating the ICD, which actually psychologically is quite hard for them to deal with. And most doctors find it hard, so tend not to have that kind of conversation. But in the patient's interest, it is actually important. So who should be offered an ICD? These are the European Society of Cardiology guidelines. So first is what is called secondary prevention. That is someone who has had hemodynamically significant ventricular arrhythmia and has survived it, but who has overall good quality of life, who's expected to survive more than 1 year. That is a class 1A indication. So they should all have an ICD. And of course, even for primary prevention, those who have significant heart failure, but are expected to live for more than a year and have good quality of life. Certainly for all those who have coronary artery disease, and probably for most who have a dilated cardiomyopathy. Also, there's some controversy about whether all these patients should have it or not. Certainly in younger patients, most would. An ICD is not recommended within 40 days of an acute myocardial infarction, even if you've had VT or VF during that, because this is expected to be a short-term thing. And in those patients who are very severely ill with heart failure, NYHA class 4 patients, it is not recommended that you put an ICD because it will not prolong life. Unless you're keeping them alive for some other intervention like a heart transplant or you're combining it with something like a CRT. What is cardiac resynchronization therapy? Basically, it's a treatment for heart failure patients with a broad QRS complex. And it can be delivered by pacing both ventricles. So with the biventricular pacemaker, you have to pace the right and left ventricle. Unlike a conventional pacemaker, which paces the right ventricle. If you combine it with an ICD, it's sometimes called CRTD. If it's only a pacemaker, it's called CRTP. And the key component, as I said, is the left ventricular pacing lead. This can potentially increase cardiac output by synchronizing the contraction of both the ventricles. So this is what it looks like. I'll show you an X-ray with it. So essentially you have one lead pacing the right atrium, one lead pacing the right ventricle, this is a conventional pacemaker. The third lead goes from the right atrium through the coronary sinus, the venous system of the heart, into a small vein, and you try and get the lead all the way out to the back of the left ventricle, and you pace the left ventricle posteriorly. So this is an example of a wide QRS complex. This is so-called left bundle branch block. The QRS duration here is about 150 milliseconds. And about a third of patients with chronic heart failure will have left bundle branch block. But equally important, about 10% of patients with heart failure who don't have left bundle branch block will develop left bundle branch block every year. So anyone following up patients with chronic heart failure, it is worth doing an annual ECG. Why? Because if you find new left bundle branch block, it is worth considering putting in one of these pacemakers. And if you look at an X-ray, I don't know whether you can see this. If you look at this, you have a lead here. This is the right atrial lead, the one going up. You have a right ventricular lead coming anteriorly. And the left ventricular lead going through the venous systems comes posteriorly in the heart. Sorry. Yeah. And this is what, of course, this is the pacing battery, and this is the generator and all the complicated electronics that does this works here. Now going back to your left bundle branch block. In left bundle branch block, the left ventricle is activated late because his Purkinje system isn't conducting to the left ventricle early enough. When the left ventricle contracts late, the synchrony between the two ventricles is lost, and that lowers the cardiac output. So that's why this is called cardiac resynchronization therapy. What it does is you pace the left ventricle with your left ventricular lead so that it beats at the right time, just before the right ventricle does. That, if it works well, will narrow the QRS complex and increase the cardiac output of the heart. So this is a randomized controlled trial on good medical therapy. And the second arm is adding this form of pacing. And as you can see, event-free survival is increased by doing this. And on the basis of this, biventricular pacing was introduced about 15 years ago. So who should be offered this? This is a slightly complicated slide. If you just look at the class 1 indications, this is hard indications for this. Patients in symptomatic heart failure in sinus rhythm with a QRS duration above 150 milliseconds and left bundle branch block, who are on optimal medical therapy, should be offered this. And in them, there's a very good chance that it will improve both morbidity and mortality. In those patients with sinus rhythm, a QRS between 130 and 150, but left bundle branch block kind of ECG, it is likely to benefit them, so it's worth doing as well. And the third absolute indication is patients with heart failure who need pacing for other reasons. So if they have AV block, if you're going to put a right ventricular pacemaker, when you pace the right ventricle, what you effectively produce is left bundle branch block. Therefore, all these patients who have heart failure and need pacing should be given a biventricular pacemaker. In patients with the QRS duration below 130 milliseconds, you should not put one of these in. And the other indications are less certain indications, so we won't go into all of them now. So how do we use all these drugs? Well, the way that we conventionally are told to use these drugs, and what NICE says is, You start, initially you give a diuretic, you start ACE inhibitor, then you add a beta blocker, then you add an MRA like spironolactone. Then you convert your ACE inhibitor to the sacubitril valsartan, and then you add an SGLT2. So that is what is currently the sort of guideline, if you like. But actually, if you think about it logically, this doesn't make a lot of sense, because you start with this, then you convert to this, then you add that. But actually, if you look at the way these drugs work, so you start on a diuretic when you have a new patient with heart failure, get them dry. They're going to drop their serum potassium, so you need a potassium sparing diuretic. And as we all know, spironolactone is potassium sparing. So we probably add the MRA, the spironolactone, right there. And the SGLT2s, these dapagliflozin type drugs, they also cause water excretion, sodium excretion, and they don't affect renal function adversely. So many people now think you should be adding them right from the word go, because you'll help to get the patients dry. At that point, instead of starting an ACE inhibitor and later converting them, it might be more sensible to start your sacubitril valsartan right then. And once the patient is stable on all these drugs, the blood pressure is reasonable, they are dry, then you add a beta blocker. And this may be the way we will go soon, but this is not what NICE would tell us we should be doing now. Last word about something called NT-proBNP, which many of you know is recommended, is used in primary care. So this is NICE's sort of schema, if you like, of how one should be dealing with these patients. They say take a detailed history and physical exam, ECG, chest X-ray, blood tests, spirometry, etc. And if you still suspect there may be heart failure, you measure the NT-proBNP. If the NT-proBNP is below 400, heart failure is unlikely. If it's 400 to 2000, they need assessment, including an echo, as they say, urgently within 6 weeks. If it's above 2000, urgently be seen within 2 weeks. Now, whether these 6 weeks, 2 weeks works in practice is another matter, but that is what NICE would like us all to do. But it's also useful to those of us who treat heart failure to assess what the medium-term prognosis is going to be. This is a group of patients at my hospital. One of my colleagues has done this work. For every patient we were referred to assess for a heart transplant, we measured the NT-proBNP. And you can see if on medical therapy, the NT-proBNP is below 1000, over the period of next 3 years, 90% are alive. So these patients are obviously relatively well and don't need further treatment like mechanical support or urgent heart transplant and so on. If you look at the group where the NT-proBNP is above 5000, so very high, so within 6 months, 40 to 50% of these patients will need some form of emergency intervention, either an urgent heart transplant or a pump to support them. So if on medical therapy you cannot get the NT-proBNP down, it's a good sign that you have to do something else. And those in between do worse than when it's low, but not quite as bad here. So these patients you have to watch very carefully and see whether they're getting worse when you have to intervene. So I think I'll stop at that point. I can go on, but I think in the interest of time, we have done more than half an hour, I think. So I will stop now, and I'm happy to answer questions about these or anything else that you want to ask me. Thank you very much.
Very good. Before taking questions from the floor, can I ask you a couple of things? I'm a urologist, and my physician colleagues think urologists are not a proper doctors. And
once they get older and they get prostate problems, they'll change.
Correct. And just give us some tips, clinical signs and symptoms of compensated heart. Patient is in heart failure but with a compensated heart, and patient in heart failure with a decompensated heart. Give us some tips.
Okay, so the most important physical sign in heart failure, which the average Cambridge medical student cannot get, but most of us who were treated in MSMA colleges should be able to get, is jugular venous pressure, looking at the JVP. When I was a third-year medical student, one of the PGs called Dr. Sethuraman, who became a prof of medicine in JIPMA many years later, he was assigned by the professor to teach us physical examination of the cardiovascular system. For 1 month, he didn't allow us to go and touch a patient. He used to say, no, you sit here and hear what I have to say. And we say, we want to auscultate. You know, when you have your new steth, you want to auscultate. Sethuraman used to say, what the mind does not know, the eye will not see and the ear will not hear. It's very true. Today, most medical students are not taught to examine the jugular venous pressure. It's the most sensitive physical sign of decompensation. So the first thing that will happen is the JVP will go up. So if your patient is at 45 degrees on a couch, the jugular venous pressure is normally just visible above the clavicle. If it is mid-neck or higher, the patient is volume overloaded. The next thing they will get, of course, is peripheral edema. Some of them will have mild ascites, but you know, before they get ascites, it will be a long time. The other thing many of them will complain about is when they're exercising, you will get, they will sometimes complain of right hypochondrial pain. Right hypochondrial pain in these people is because of the hepatic congestion from a raised venous pressure. Yeah, and if you examine the venous pressure, you will get it, but if you don't examine it, then you won't. So well compensated heart failure patient will feel well, JVP will be normal, there'll be no edema. Yeah, they might still have abnormal ventricular function. You might still have a big heart on a chest X-ray. Of course, echo will show abnormal function. So I think that's the most important thing I would say. So for all of us, if we can go back to our undergraduate skills of examining the JVP, I still use JVP examination in the intensive care unit, and all the ICU nurses, especially now we have lots from India, they'll all say, why are you doing this? And I'll say, I want to see the neck vein. They'll say, but you have a CVP line. Half the CVP lines will be blocked. So the CVP reading will be wrong. Okay, and I'll tell them, your CVP is saying 5, I can see the JVP at his ear. What is the meaning of your CVP? So these old physical signs still have a role.
Right, thank you. Thank you. Right, another thing, I'm a urologist. When I do TURP, I use bipolar current under saline to resect the prostate. Now, all your new devices in the heart, do they have any impact on using electricity for the prostate?
Normally, I think if you're doing these things, it's better to deactivate an ICD cell.
Okay.
So that you don't get any interference. I mean, most of the time it's fine. Nothing's going to happen if you do it there. But when you're doing it under general anesthesia, you don't need an active ICD. If you get an arrhythmia, you have an anesthetist there who can shock the patient. Why take a chance? So if you want to be safe, just deactivate ICDs. You don't need to do anything else.
Right. Okay.
The patients who have mechanical support with pumps and things are an entirely different matter. Those you need to get somebody. You need to talk to somebody about what to do at the time. But those are still very rare now, so you're less likely to see it.
Okay, right. Well, thank you. Now I leave to the floor. Please put your questions on the chat box, and we will call you one by one. I think there's already some questions. 1 second.
Diagnostic criteria for heart failure with preserved ejection fraction.
Okay.
So heart failure with preserved ejection fraction means you're...
Do you know who asked the question? Because we want to see the face of the...
Hi, it's me, Ganesh.
It is Ganesh from Edinburgh, yeah. So Ganesh, as you know, this is one of the harder things for people to diagnose. But ideally, you need to have, of course, signs and symptoms of heart failure. But really, you also need to have some evidence of abnormality in the heart, and the commonest thing will be an enlargement of the atria. Yeah, so ventricular function may be normal, so the ejection fraction is normal, but the atria will be enlarged. If you measure diastolic function in the heart, which the echo can do, it may be abnormal, but there's still a lot of variability between people in how they measure and what they do. So the commonest abnormality I think you'll see is enlarged atria or ventricular hypertrophy. So people say with long-standing hypertension, or even with age, as the heart gets hypertrophied, its filling characteristics change. So it still contracts well, but the filling of the heart is going to be impaired. so-called diastolic heart failure. Those patients are the ones whom we talk of as HFpEF. Now, at the moment, the only drug shown to have any benefit is moderate doses of diuretics for those who are volume overloaded, okay? And of course, treatment of the underlying cause. So if you're hypertensive, you have to treat that. But as I said, this sotagliflozin trial, for the first time, has shown some benefit. To be fair, also there was a trial with eplerenone, the spinal actin-like drug, which came out neutral. But if you look at subgroup, this was a trial done in the US, Europe, and in a large number of patients from the old Soviet Union. If you exclude the Soviet Union patients, there was a positive result in the rest. We're not quite sure what that means. But many people feel that spironolactone or eplerenone might have a role. And if this SGLT2 effect is confirmed, that might be the next drug.
Right. Jayan, if you don't mind, I will call out one by one.
Yeah, please.
Okay. Next question comes from Kishore Reddy. Kishore Reddy.
Typing out my questions, but if you don't mind, I'll ask them straight away. That's okay?
Yeah.
I have two questions and one observation. My first question is, you mentioned about hypoglycemia in the presence of best medical practice with enestro, spironolactone, and amphiloglossin. I thought with the spironolactone, it's more hyperkalemia that you need to be concerned about because you have a problem in the hyperkalemia and the use of enestro. Am I right or wrong?
Yeah, no. If I said hypo, it's wrong. They cause hyperkalemia. What I said was when you start the loop diuretic, you're likely to cause hypokalemia. Therefore, when you add your spironolactone, apart from its other benefits, you also will stop them being hypokalemic.
Okay. And my second question was, when you talk about beta blockers, are you talking about cardiac-specific beta blockers or are you talking about general beta blockers?
So there are several beta blockers now that have been shown to be beneficial in heart failure. It may be that not all beta blockers are the same. So it is recommended that we use one of the beta blockers that has been shown to be beneficial in heart failure. Commonest ones used in the UK will be either bisoprolol or carvedilol.
What about nevabilol?
Non-specific beta blocker. Yeah.
What about nevabilol?
Nevabilol has been shown, yes, in this year's trial. So nevabilol, bisoprolol, and carvedilol are the ones that I would use. Metoprolol has also been shown to be beneficial, as I showed in that slide. But the particular formulation shown that was used in the trial was a long-acting formulation, which is not always available. There is some data saying that carvedilol was better than metoprolol, but it doesn't matter really. I think any of these drugs are okay.
Okay. And one observation was, and correct me if I'm wrong here, the other subtle changes that you notice in the cardiac failure situation is early or subtle pulmonary edema. Do you find that in your practice?
So pulmonary edema you see with acute heart. What I mean is early onset heart failure. When you have a new patient with heart failure, pulmonary edema will often come. Okay, but when the patient first comes and says, "I'm short of breath," you may not hear anything. You know what I mean? To get physical signs will be late. If you do an X-ray, you might find that there is upper lobe blood diversion. There might be interstitial edema, but before we see, the characteristic signs that we of pulmonary edema, that is quite late. In chronic heart failure, patients who have been in heart failure for years, who then decompensate, pulmonary edema is less common. The reason for that is as the left atrial pressure has been high for a long time, the pulmonary vasculature, the pulmonary venules and arterioles and things get thick-walled. They don't leak fluid quite as easily. Right? So although the pressure is high, they may not have florid pulmonary edema in terms of fluid seeping out into the alveoli. So the patient who comes with an acute myocardial infarction, where the left ventricular and diastolic pressure and left atrial pressure acutely goes up, those are the ones where you get pulmonary edema early.
No, the reason I asked this question, Dr. Parameshwar, if you don't mind me pushing you on this.
Sure.
I'm talking about a personal experience. I was treated with inhalers for a long time in the most prestigious institution, thinking that it was a respiratory problem. And definitely the CT was done to see if there's any underlying problem.
And that showed
very subtle fluid in the horizontal fissure. And that's when you maybe know this gentleman, Dr. Rakesh Sharma. He put me on this cardiac stim, and he said, look, you've got early cardiac failure. That's the reason I asked the question.
No, that's true. But that's my point. If you have to do a CT to see the interstitial edema, the physical signs won't be there. Goes back to my point. I don't know if it would have been so, but if somebody had looked at your JVP, it might have been high before your pulmonary edema.
No, I was playing 18 holes of golf. That was not a problem.
Your wife said you're in cardiac failure.
My wife said I was in cardiac failure. Go
See, your wives are always right. That you should know. Yes, I know, Rakesh. Yeah.
Okay.
So yeah, you're right.
We don't want to get into that area.
No.
And finally, Dr. Parameshwar, you kindly agreed to share your slides. I would very much love to get your slides, sir, because I thought it was a very eye-opening talk you just gave.
Yeah. Some of the slides, the reason it's quite a large file. I'll see if it comes over.
Actually, we are recording this and then we edit and send it to all our members.
That's fine.
Okay. Thank you very much.
Thank you.
That's okay. You can do that.
Yeah, thank you.
Lovely talk. Thank you.
Thank you. And next question, Jayabalan. Please unmute. Yeah.
Thank you for such a great talk.
Thank you.
You know, those days when we were taking exams, we used to think of Ishwar for passing to prevent the failure in exams. Now I see if you want to failure from the heart, cardiac failure, we have to think of Parameshwar. Sir, I am from Stanley Medical College and I was a student of P. Christian Kuti, PKK, one of the greatest cardiologists. Before I ask my question, I share that experience with you because he used to say there are 4 cardinal signs of congestive cardiac failure. And we should remember that even if we are woken up in the middle of the night, that is engaged pulsatile neck vein, basal crepitus, bilateral dependent edema, and enlarged tender liver. I have seen this patient, he will have a tender liver. We will be about 35 students in that batch. Everyone will poke it, say, you'll shout, oh, yes, he has got an enlarged tender liver. The question I want to ask you is a very simple question. You know, I am an orthopedic surgeon. We are very simple people. If there's a fracture, we fix it. If there's arthritis, we replace it. That's what orthopedic, unlike you, cardiologists do many things. So simple, very simple question I want to ask you. I'm also digressing from the topic for today. The question, sir, you know, if you see a 50-year-old gentleman, first time diagnosed of hypertension, what will be your recommendation of treatment? I asked my GP friends, I asked my cardiology friends, each one says something. Whereas it is nice to get it from the horse's mouth here. And so what is your first line recommendation with no comorbidities? And the second one is, would you put a small dose beta blockers considering its cardioprotective action?
Okay, so if there's no comorbidity, first line therapy that is recommended is either a calcium channel blocker or an ACE inhibitor. Beta blockers are less effective and you would not normally use it as a first line. So either an ACE inhibitor or ramipril or whatever, or calcium antagonists like amlodipine, and many of them will need both. So those would be first line. Beta blocker and so on will be only after that, second line.
Thank you.
Because they are hypertension, don't forget, you're going to take drugs for 20, 30 years. You want the drug not only that works, but has the least side effects. Beta blockers, you know, fatigue and things are more common in that. So I think most people would not use it as a first line. And hopefully if you treat hypertension well, then you won't get the heart failure anyway. That's so.
Thank you, Jayan.
And I knew Dr. I knew the particulars that you mentioned when I was a child, because he knew my father.
Thank you.
Same place.
Next question comes from Rangarajan. Rangarajan suddenly frozen and he's re-emerged now. And he has a question.
Thank you, Jayan. I enjoyed your master class. I'm a pediatrician and we don't see many scenarios of heart failure, but I enjoyed your talk. And I have a few questions, based on your talk. You said about achieving euvolemia before putting a patient on beta blockers, if I'm right. How do you go about getting euvolemia in these patients?
So if you have a newly admitted patient in hospital, usually it'll be intravenous to diuretics. And I think when I say euvolemia, what I mean is there should be no peripheral edema and the jugular venous pressure should be normal. So if not, you get rid of the edema, but the JVP is still banging the ear, that is not euvolemia. That is a mistake that many people make. Because if you start the beta blocker at that point, many of them will then get worse again. Whereas if you can get rid of all the fluid and then use beta blockers, ACE inhibitors, all these, of course, are prognostically important. They cause, reverse remodeling of the adverse remodeled heart. But to achieve that reverse remodeling, you need the fluid out first. So I think getting rid of edema and getting the venous pressure down. The big mistake is everyone wants to get patients out of hospital fast now, isn't it? No beds, everyone wants to. So biggest mistake if we send them out too early, so we want to start the drug early, those few extra days might keep them out of hospital longer.
Thank you. The other thing is you talked about SGLT2. Does it help in weight loss, or is that one of the good effects, or what would you say?
I think it does in diabetics. I think there is some weight loss with it. In the heart failure patients, the weight loss that you get is because they lose water and sodium if you start it early. But if you look at it in a chronic stable heart failure position, you won't see much weight loss.
Yeah. Thank you very much. Thank you. That's it. Yeah.
May I just substantiate the question that was just asked? The SGLT2 you do lose weight. That's one of the reasons why they give it for diabetics.
Exactly. But in the heart failure population, you might not see that, is what I mean. Yeah.
Thank you. I think Ganesh from Edinburgh, he has another question.
Yeah. I'm one of the endocrinologists in Edinburgh. We do often encounter patients with advanced heart failure, young Duchenne's, cardiomyopathy, etc., who are on amiodarone coming with florid type 2 amiodarone-induced thyrotoxicosis.
Yeah.
We encourage a cardiologist to stop it, and they are always hesitant because they don't have an alternative option. What would be your choice if amiodarone has to be stopped? Do you have alternatives for young advanced heart failure?
So I think this is a common problem, as you say. I think we do try and stop it because we find that to control the thyrotoxicosis without stopping the amiodarone is really hard. We've even resorted to thyroidectomy in some patients. But obviously, it's not something you want to do very often. I think many people would now say that you should try and minimize long-term amio use because of things like this. And in fact, if you can get them on an adequate dose of beta blocker, then the antiarrhythmic effect of the beta blocker often means that you don't need the amiodarone. But there are patients who get symptomatic ventricular tachycardia, even though you have an ICD and you want to minimize the number of ICD shocks, that way the amiodarone helps. So then you have to balance one against the other. If you can manage them, if you say to me that I can manage the thyrotoxicosis in spite of continuing amiodarone, that's one thing. But often we find it's very hard. It doesn't go away. And in the extreme cases, we have done thyroidectomy. You don't get the problems that you have. But it's a big problem. You have to say what is a bigger problem at the time. Very often you find that you stop the amiodarone thinking, oh, you're going to have a big problem, but things don't get worse.
Yeah, exactly.
Mostly so my default position is if they get thyrotoxicosis, we try and take them off the amiodarone. in spite of the potential harmful effects. But thyrotoxicosis is also going to make the heart problem worse anyway. So overall, I think it's better to stop the amiodarone, because many patients are continued on amiodarone far longer than they need to be. I mean, we all do it. I'm not saying blaming other people. I'm sure I also do it. Patients on it for whatever the reason was. They're doing well. It's much easier to continue than to take the chance of stopping, potentially allowing them to decompensate, isn't it? So it's much more tempting to leave them. But I think that is our mistake, that I think we leave them on longer than they need to be.
Thank you very much.
Thank you, Jayan. Jayan, there's an audience from Sam Muthusamy from Chennai. I think probably would say hello to you. Swami, just can you unmute and talk?
Hi, Jayan. You remember me?
Yes, of course. Nice to see you again. I remember you very well. Yeah.
Okay. How are you doing? Okay.
Yeah, very well. Thank you.
Good. Nice to listen to your talk. What will you do on a patient who is 87, has got ischemic cardiomyopathy, moderate LV dysfunction, in congestive cardiac failure, poorly controlled diabetes, and has got a Mopitz type 1 heart block. Once you control the heart failure, will you put him on a pacemaker? If so, will you go for CRT? He got RBB, not LBB. What will you do?
So so I suppose it depends on what the quality of life you expect, man, because how old did you say? 87.
87. He is a very, very active person.
Yeah.
And daily look at around 1,000 emails a day.
Okay.
A very busy man, government employee.
Yeah. Ideally, if you got heart block, then otherwise you can't use a beta blocker. If you're going to pace him, you should do CRT, I think. You could not put an ICD in him though. I think CRT.
Of course, he hasn't got any VT or anything. Yeah. Mainly congestive cardiac failure with RBB, but Mopitz type 1 heart block.
Okay, type 1 is borderline, isn't it? So I think so it's less certain. So one way of dealing with that, I think, would be, okay, he's also got poorly controlled diabetes, so I think it's a good indication for him to be on an SGLT to inhibitor to control heart failure and the diabetes. You could try him on a low dose of beta blocker and see what happens to the
he's already on
and the PR interval. Huh?
Yeah.
If the PR interval is getting longer.
Yeah, it's a classical.
In that case, I think ideally, yes, use CRT, I think. Ideally.
Okay. Right. Thank you.
Ideally. If you don't, if you say he's an active person, then fine. Don't think about the age and do what is best for him.
He got a CKD as well. That's another problem. I forgot to check.
What has he got?
Very, very
CKD.
Chronic
renal failure.
Yeah.
From prostate?
Very complex. Oh, well, he may be having very complex problem, unfortunately.
Right.
Yeah, that happens. Yeah, that's what happens to us as we get older, isn't it? We don't get one.
Exactly.
We get multiple.
Exactly.
Yeah.
Exactly. Yeah.
Yeah.
Great.
Yeah.
Thanks, Sami. You've been keeping an 87-year-old alive, and he's looking at 1,000 emails daily. I'm sure he will be in politics or cinema industry.
He's a government employee, I said.
All right. Okay. Well, thank you for joining us. Next question comes from Sivalingam. Sivalingam, please. Jayan, there's a request from Kishore. Would you mind to type your email ID to our members?
Okay.
Sure.
Thank you. Right, Sivalingam. Siva is an anesthetist.
Okay. Thank you, Raju. First of all, I'd like to thank Dr. Parameshwar for the excellent talk covering up to starting from the digoxin, ending up the latest, which I enjoyed very much. Thank you, sir. Now, my question is the role of digoxin in heart failure. I know it's almost obsolete, but as it's still got a useful role occasionally in people with acute LVF associated with fast AF, because in this extent, I'd like to share my experience with you. When I was doing an eyeless cataract extraction, the local anesthesia, local block, and monitoring the patient awake. He's an Indian gentleman, Asian gentleman in his early 60s with a lot of cardiac history. His heart disease, previous coronary artery bypass graft, and atrial fibrillation, on heart failure, and medication, variety of medication, hypertension, diabetes, and insulin, all sorts of things.
Yeah.
Now, halfway through, when the lens was extracted, surgeon still hasn't put the new lens back in, patient became acutely breathless, and saturation dropped progressively, started going 90, 94, 91, 88, and 82. And pulse, the ECG showed fast AF, about 180, 90, and it was wheezy chest. We sent for a physician, come immediately, please, urgent call sent out. In the meantime, I had to do something, otherwise it's not. Eye unit is far away from the main unit of the Royal Bolton Hospital, Bolton. It will take 20 minutes for them to come, and he managed to survive 20 minutes. So I gave IV digoxin, 0.5 milligrams, slowly diluted, 20 minutes syringe slowly, IV morphine, IV amiodarone infusion, and furosemide. I asked surgeon to leave off, give oxygen 100%. And gradually the pulse rate came down, and saturation started to pick up, and 110 from 100 to 200 or something. Saturation back to 94, 95. And I said, surgeon, you can complete the operation now. He has put the new lens back in, half the eye open. So complete the operation. Once I sorted all these things out, then the medical registrar came, can I help you? I said, thank you for coming, but of course need aftercare. I can't, it's not, I had to hand him over to them to take over and investigate him and do the needful. And so I think the digoxin helped on that day.
Yeah, so there are two things to say. Yes, I think in that sort of situation, it's certainly okay to use. It's not obsolete for heart failure. I mean, I think it still has a role. It has a prognostic benefit. So if after getting all the other drugs in, if the patient is still, complaining of heart failure symptoms, then digoxin may help. Some of them will feel better. So using a low dose is certainly not wrong. The last time anyone did a trial with DIG was about 2003, and this was before pacing was used, before the blockers were used a lot. So this was in patients with ACE inhibitors and spironolactone. What the trial showed is that although there was no prognostic benefit of using DIG, hospital admissions with heart failure were decreased. So it's not like this is even in sinus rhythm. So it's not an obsolete drug. It can be used. Of course, if you use all the drugs that you've got, if you want to add another drug, you need to have a good reason. So I think if patients continue to complain of symptoms when they are on so-called best medical therapy, it is not wrong to use DIG. Secondly, there are patients, we can say these are drugs we should use. Not everyone will tolerate every drug. Some people will, you will not be able to give them sacubitril valsartan because their renal function is bad. Like, Sam has talked about his 80 patient of 87. I don't think you will be able to give them a full dose of ACE inhibitor or things like that. So I think DIG still has a role in some people. Acutely, yes, I think, mostly when they suddenly take off, that something is causing the heart rate to go up, isn't it? Something has...
Yeah, fast AF in this situation.
Yeah, but fast AF is caused by something happening. It's the sympathetic nervous system has been activated by something else happening. So yeah, in the short term, yes, to control it, that is perfectly okay. It's not. So it is not an obsolete drug. It still has a place.
Okay.
It's gone down with time. That's all.
There are also people who say digoxin has been discovered today. It won't pass. It won't find a place in pharmacopoeia because narrow therapeutic index. I mean the difference between the therapeutic dose and toxic dose is very narrow. So you need to handle very carefully if you use.
That is true, but I think that's because if you look at the past, we look at the 60s and 70s when we were in medical college. By the way, we have met, that, no?
Sorry?
We have met in the past. I don't know whether you remember. But anyway.
No, I'm an ex-Gipperite too. No,
I know that. That's why I know you.
Okay, proud Gipperite. I know that. In 72.
I know.
And so very doubly, I'm proud today of having you giving this.
We have met at the Gipper meetings as well.
With your array of excellent institutions you have been to. You have been to the best of places. I don't know how you guys do it. Loudale, Jipmer, Ames, and then Brompton Hospital, now Papworth, Center of Excellence. And we feel very proud of you.
That's another long story.
Yeah, just one more comment, Parameshwar, before you go.
Yeah.
I just read 2 days ago in the paper that even people with a normal blood pressure after plus 40 or 50 years of age will benefit by taking an antihypertensive tablet. Even when blood pressure is normal, it claims it reduces the stroke rate by 10%. But this is early, somebody has to prove it and all these trials, everything. But it's just, we may hear about it in future. Interesting.
Possible.
Yeah, thank you.
By the way, my name is Jayan, and please feel free to use my first name.
Jayan, okay, Jayan.
Everyone is being very formal, you don't have to be.
Okay, Jayan, thank you.
Okay, thank you. Well, that's a catch up after many years. There's another question from Ganesh in Edinburgh.
Yeah.
Ganeshan?
It's from me, Visweswaraya.
Oh, sorry.
Raju.
Right.
That's my pet name in village.
All right.
Just a question and comments from Jam. Hypertensive LVH and mild dysfunction, LV dysfunction, is it reversible with all advice from cardiologist? And if it is reversible, how long does it take to reverse? And does exercise aggravate already existing LVH, hypertensive LVH?
So certainly the LV dysfunction does reverse, that's for sure. And it can reverse reasonably fast within 6 months to a year, okay? Hypertrophy, it can. So the trials with the ACE inhibitors have shown that the LVH does decrease. It may not go back to normal, but certainly it can become less thick, yes. How does exercise aggravate? It depends on what. If you're talking about normal, walking, mild jogging, no.
Normal walking, 1 to 1.5 hours.
That's fine. That's not going to, no, that's actually good for it. It won't make it worse. The only things that might aggravate LVH from an exercise point of view are extremes of exercise. The marathon runners and ultra marathon people and all that. That's a separate issue. But for most of us, that is not an issue. So I think the kind of exercise that most of us will do, I don't think it'll make it worse.
Thank you.
Right, excellent. I think that's the last question. Looks like it. It's an hour and 20 minutes. That's very good. Any more questions from the floor, or shall we close the meeting?
I have the last question. So sorry, probably again. It's about the ferritin you've been talking about in heart failure. Is this iron infusions universally accepted among all cardiologists, or is it universally accepted throughout the world to infuse iron for people with ferritin less than 100?
Yeah, it's now part of various, guidelines as well. If you look at the European Society of Cardiology guideline, it is actually part of it. There are at least 2 or 3 trials now showing that. So I think more and more people are actually doing it. Yeah, I think certainly all the heart failure docs do it now. So this is in heart failure patients only. Yeah.
Yeah, that's in heart failure. Yeah.
In heart failure patients, it is now. I don't think everybody's doing it, but it is part of the guidelines. So I think more and more will start doing it.
Excellent. Thank you.
Okay. Jayan, that's a very, very informative and excellent talk. And even urologists can understand some of the heart failure treatment now. So thank you for taking your time and to be with us today. You have provided your email, and I appeal to our members, if you want to contact Jayan, please do so. And then I thank the MSMA committee members, in particular Rangarajan. Rangarajan, he identified you and brought you here today. Thanks, Ranga. I thank all the members who has given that time to be with us today. And special thanks to Sam Muthusamy, who joined us from Chennai. And then I thank my co-host Sivapriya and Elil. Are you there?
Elil uncle had to go.
Okay.
And, yeah.
She's a wonderful co-host for our meetings. Thank you, Priya, and we
No
will
problem.
next month.
Definitely.
Next month, first Saturday, Saktidharan is coming back. The man who gave us a talk about yoga, the principles and theory of yoga, he is coming to show us some practical sessions. So we will meet the 5th of June for yoga, practice of yoga. And Jayan, you are welcome to join us.
Thank you. Yoga, some people say, is not good for heart failure as well, you know. So,
oh, well done. Yeah. So there you are. Prevention is better than cure. Yeah.
You can lower blood pressure.
Yeah. Can I just say, I put my work email also there. I will answer. I will see that more often than the other one. So if you want to use the work email, feel free to do so.
Okay, good. So if you haven't got any other things to discuss, I declare this meeting come to close. Thank you for joining.
Thank you all.
Thank you.